imagine that when a 6 millimeter pupil comes down to 3.5 millimeters, it reduces the operative field by 66%. Can you imagine if you have only 1.7 millimeters to work on? What might go wrong? Well, about everything. Hi, I'm Dr. Biljana Kuzmanović Elabjer, and in this video we'll dissect this case, the challenges encountered, the techniques employed, and the role of meticulous planning in achieving a successful outcome. Safe phacoemulsification of the typical cataract, that is 9 to 10 millimeters in diameter, requires 5.5 millimeters of the rhexis and 6 millimeters of a pupil size. So any size smaller than 6 millimeters is associated with increased risk of surgical complications. For example, vitreous loss is increased by a factor of 2. There are myriad causes for the small pupil. Aging, diabetes, IFIS, pseudoexfoliation syndrome, surgery, trauma, flux, etc. Small pupil can either be elastic or non-elastic. An elastic may be expendable, like a rubber band. The rigid one is, on the other hand, very strict, like a band, and you can only tear it. And this was an 82-year-old female with pseudoexfoliation syndrome. She has secondary angle closure glaucoma, YAG laser iridotomy is performed, circular posterior synechiae, and Fuchs endothelial corneal dystrophy. And she had a pupil diameter of only 1.67 millimeters as measured on pentacam, and this was a non-dilating pupil. The preoperatively measured anterior chamber depth was only 2.3 millimeters. So you're working in a very tight space with almost no endothelial cells. And this was 4+ Christmas tree cataracts. I had to perform viscosinecholysis first to be able to put iris retractors on, that I prefer because I want to have a stepwise pupil enlargement. Because of the posterior synechiae, I really want to tear them slowly, and the iris retractors allow me to go from one to another to achieve the final size and the shape of the pupil. Once all the retractors are hooked in, the gradual tightening allowed for an even tearing of the synechiae. This was 4+ Christmas tree cataract. It means that I just had enough peripheral red reflex for a capsular rhexis. The iris retractors were used because, and that was one of the reasons, to reposition them and use them as a support for a capsular bag. So 2.3 millimeters, it's a scary depth. So instinctively, one would use high IOP parameters to deepen the anterior chamber. However, I was using low IOP parameters because I have a active Sentry handpiece of a Centurion vision system that has integrated pressure sensor. It means that keeps stable my anterior chamber and reacts when there is a danger of surge. So I use the IOP setting of 30 millimeters of mercury, 575 millimeters of mercury for vacuum, and 28 cubic centimeters for aspiration flow. And after coaxial irrigation aspiration, IOL was implanted, and the retractors, the haptics rotated to achieve horizontal position to decrease dysphotopsia. At the end of the surgery, iris retractors were carefully removed because they were set under the lens capsule, and the thorough cleaning of the viscoelastic was mandatory because we are talking of the glaucoma patient, so we wanted to avoid postoperative IOP spikes. And at the end of surgery, cefuroxime was given. I put cefuroxime not just in the anterior chamber, I use additional amount to hydrate the side port as well. And 4 milligrams of dexamethasone was given at the end of the surgery subconjunctivally. Our patient ended up with a perfectly round pupil and best corrected visual acuity of 0.8 3 months postoperatively. Cataract surgery in a small pupil is always in a higher incidence of postoperative inflammation, IOP spikes, pseudophakic cystoid macular edema. So I would recommend usage of the most potent corticosteroid drops frequently and for an extended period of time postoperatively. The key lesson I learned from this small pupil case is that the low IOP parameter setting addressed different conditions coupled with a small pupil. It protected the iris, the corneal endothelium, as well as the perfusion of the optic nerve. And this was all essential in a patient with small pupil coupled with a glaucoma and corneal dystrophy.